Okay. All right. Welcome to the Berman Institute of Bioethics seminar series. I am delighted to have the opportunity to introduce Jennifer James. She's an associate professor in the Institute for Health and Aging in the Department of Social and Behavioral Sciences and the Bioethics Program at UCSF. Jen's a qualitative researcher and Black feminist scholar who conducts community-engaged research on the intersection of race, gender, and health. Her empirical ethics research is grounded in Black bioethics and challenging and advancing the way justice is considered in health and healthcare. Her current work is focused on experiences of health and illness for people who are or have been incarcerated. She holds a PhD in sociology from UCSF, a master's in social work, and a master's in science in social policy from Penn, and a BA in political science from Yale. She's also currently, or maybe right-ish, just at the end, 2 more months, Greenwall Faculty Scholar, and is conducting community-based research on the forced sterilizations that occurred in California's women's prisons. Please join me in welcoming Jen James.
Thank you so much. So excited to be here. See if I can find the mouse. All right, I'm just restarting this little timer thing so I know where I am. Okay. Hi, everybody. So I am excited to talk to you all a little bit today about some of the work I'm doing in a few different areas. And so this was originally going to be the title of my talk. And now it's like not the title of my talk anymore. And some of that is based on they ask you for a title of your talk and you don't know what you're going to talk about yet. And so then you try to kind of talk to it or not. But actually, in some ways, I am talking about something a little bit different than what I planned, based on a few things that are going on in the world and that I've been seeing and conversations I've been having that have led me to think a little bit differently about both how I wanted to frame my talk today and how I'm thinking about some of the issues related to carcerality and abolition and ethics and justice, and all words that I will use. So this talk totally could work anyway. But I wanted to just start by acknowledging what's been going on our college campuses. I just was reading in the news that Hopkins just came to an agreement with protesters here. So it seems like things are ending peacefully, which is great. But as someone who's been on an academic campus my entire adult life, as many of us have, and who thinks often and critically about policing, watching the responses of so many universities to the protests that have been unfolding across the country has been shocking and disturbing in a way that it probably shouldn't be for me, but it has been. And I've realized the ways in which my understanding of the academy as a place founded on free exchange of ideas and pluralism and academic freedom and the right to protest is different than many others in these spaces. And I've sort of watched people I know, my colleagues, be sort of violent, be very violently arrested, and seen faculty, staff, and students facing chemical weapons and rubber bullets and physical assault while protesting, the deaths of tens of thousands of people has been interesting for me to consider sort of as an ethicist, as an academic, and what that means for my work that's sort of at this intersection of policing or carcerality and other spaces. And I was going to focus today really specifically, and I still will, on policing and carcerality as it intersects with medicine. But I wanted to shift to make sure we're all really thinking about sort of our collective complicity in unjust systems. And, I'm a medical sociologist, which means I sort of professionally sit in my ivory tower and critique medicine, doctors and nurses and the work that they're doing. And in a way that's easy for me to do because I'm not the one in the room making life and death decisions. But all of us in the academy have perpetuated or continue to allow for various forms of harm to happen in our name, right? So, of course, if you provide direct patient care, I think there's important obligations and responsibilities to consider. But if you teach or you do research or you take funds or you give funds or you rely on carceral systems to maintain your way of life, then all of us have to think about the role that policing has and continues to play in the work that we're doing. And so I want to make sure that that is sort of a lens as we think about a broader understanding of carcerality in academic medicine. The other thing I want to raise is I've had the opportunity to be in conversations and different colloquium spaces with some really amazing thinkers who have informed a lot of my work that I'm going to present here. And this is Yolanda Wilson, who's at St. Louis, Amy Medeiros at UCSF, Rakaya Yerby at the Ohio State University. They're very insistent about the V, and LaTanya Trotter at UW. And I wanted to sort of name them because their conversations have been really influential in my thinking, and because in a few places I'm going to, with their permission, be referencing some of their unpublished work. So I will let you know about that. So this had been the point that I was planning to get to, and I still will, which is my thinking about the way that carcerality shows up in lots of types of healthcare. And it's been grounded in this idea of like medicine has been complicit in creating the framework necessary for racism, which of course has led to carcerality and policing. And in some ways, my thinking of this gets more and more complicated all the time. I love just like, let's just throw every word I can think of on a screen. But, you know, medicine led to this idea of scientific racism, which led to the ability for us to perpetuate structural racism, which of course paved the way for mass incarceration, which creates more interpersonal and structural racism, which bleeds into medicine, which then, you know, uses policing to maintain itself. But I want to broaden this out to think about academic medicine or academic healthcare as research, teaching, and clinical care, and the way all of those work together to both rely on and perpetuate racism. They necessitate different forms of vulnerability, and how they challenge or allow for different notions of safety. So that's really what I'm going to try to think about today. So we're going to go on a little bit of a historical and theoretical journey, a few of them, and then come back to sort of where my work currently is. So I want to start with this idea of racial capitalism. Are folks familiar with racial capitalism? Anybody read any Cedric Robinson? A few nods, a few maybes. So racial capitalism is a theoretical framework that describes how hierarchical social formations, specifically racialization, are foundational and embedded in the structure and site of capitalist accumulation, right? So it describes how various processes of accumulation require loss, disposability, and the unequal differentiation of human value. So racism enshrines the inequality that capitalism requires. So in order for us to treat people differently, in order for us to maintain a system like slavery, we relied on certain forms of labor, right? In order to have those forms of labor, we had to see people as distinct from each other in some way. Racism fills that need. And while the mechanisms of dispossession, of othering, of categorization have changed over time, the framework of capitalism's reliance on and creation of inequality has remained a constant feature of the US capitalist system, right? It relies on this logic of categorizing people and establishing an other based on a differential hierarchical framework. So capitalism needs violent modes of othering, right? It needs racism, homophobia, ableism in order to sustain itself, in order for us to believe some people deserve less than others. We have the right to take property from some. We have the right to treat others differently. And this is a quote on the side. It's from someone I've interviewed for my current research who's formerly incarcerated, who's saying we're a subset of the human race, right? We're less. She sees how through her categorization as someone who's been incarcerated, she's been categorized as an other. And medicine and science have played a big role in perpetuating this idea, right? So this on my right, your left, is a depiction from the science of phrenology, right? A form of scientific racism, understanding mapping differences between types of people. And this person here is Samuel Cartwright, who was the person who coined the term drapetomania. People know about drapetomania? You nod. So drapetomania was the disease that afflicted people who were enslaved that made them want to run away, right? And when he talked about this, he sort of said, if they nonetheless become dissatisfied with their condition, they should be whipped to prevent them from running away. So the appropriate medical intervention from a doctor was to whip people who wanted to run away from slavery because it was a disease that needed to be cured. So when slavery ended, when 1865 ratified the Constitution, we left this exception. We had this problem in our society, right? We had all these people who we've been told were other, are different, are less than from us. What do we do with them? We left this exception in the amendment that ended slavery that said except for punishment of a crime. And this has led many scholars, many people in the lay press to put forth this idea of racism being a continual through line in American history, where we went from slavery, where we obviously heavily policed, forced people into servitude, to Jim Crow, where we had specific laws to keep Black and white people separate, to keep people unequal, and into a system of mass incarceration, where we use the law to lock people up for long periods of time. And I like to point to this quote from someone who worked in the Nixon administration, who really says pretty clearly that they did this intentionally and that it was about race, right? So he's saying the Nixon White House had two enemies, the anti-war left and Black people. You couldn't make it illegal to be against the war, be Black, but by getting the public to associate hippies with marijuana, Blacks with heroin, criminalize them both heavily, we could disrupt those communities. Arrest their leaders, raid their homes, break up their meetings, and vilify them. Did we know we were lying about the drugs? Of course we did. So we had this very intentional campaign that was wildly successful, right? We went from incarcerating 350,000 people in 1970 to more than 2 million at our peak in the 2010s. And we know that who those people are varies very widely based on these categorizations of difference. So people have probably seen this statistic, 1 in 3 Black men born in 2001 will likely go to prison. So disproportionate by race. Native folks aren't on here, also disproportionately likely to be incarcerated. But then it flows through with every category of people that we've historically othered and disliked and treated poorly in this country. So queer people, trans people, poor people, people with disabilities, all much more likely to be incarcerated. And so I've been arguing in my work that we're creating this new underclass, this new classification of people who are different, who are an other, that we are allowed to treat differently, right? It's no longer legal to refuse to rent an apartment to someone because they're Black, to refuse a job to someone because they're Black. And in some neighborhoods and parts of the country, in some places, it's distasteful to express overtly not liking someone because of the color of their skin. But it's both legal to discriminate on the basis of felony conviction, incarceration status, formerly incarcerated status. And it's often seen as reasonable to have a fear of someone or to treat someone differently based on that status, right? And so this is a thing. So I want to think about how these things have been linked, right? How explicitly the scientific side of understanding racism has been linked to the way we view people who are incarcerated and the way we've continued to find new avenues for creating conditions for vulnerability and creating conditions that benefit academic healthcare, medicine, research, clinical care because of this work, right? So folks are probably familiar. This was a study that came out, 8 years ago now, that looked at how both the lay public and medical trainees understood different stereotypes of Black people, right? And so it asked, like, do they feel pain? Are their bones thicker? Are their brains smaller? All these kind of different things. And this is one of the one I want to point to today is this one that Black skin is thicker than white skin. And so looking at, both the online sample, which is like lay public, medical students and residents, we see that most people, a majority in many of these cases, 25 out of 28 residents agreed that Black skin is thicker than white skin, right? And this is like today. These are people who are just finishing their training, right, to become doctors. So that's concerning that we still have this idea of Black people and white people as genetically, inherently, biologically different. We've seen the way that this is continuing to be challenged really just in the last 4 years with the EGFR calculator being changed, the VBAC calculator, all the places this shows up. But what I'm interested in too is the way that this shows up in how we treat people in our criminal legal system. So we already know that Black people are more likely to be incarcerated, brown people are more likely to be incarcerated because of policy and also because of our perceptions of them. But this was a couple articles that came out last month, which looked at botched executions. So the death penalty is still legal in many states in this country. They looked at the rates and found only ones that were identified as botched. There may be more botched cases. And Black prisoners, Black people who were on death row, who were executed, were significantly more likely to experience a botched execution, which often involved an execution lasting more than 45 minutes. I think in a quarter of those lasting more than an hour. So really a torturous experience. And they talked specifically about 3 states, Georgia, Arkansas, and Oklahoma, all of which had about 30% of the people they executed were Black, and about 85% of the executions that were botched were Black, right? And so when they were talking about how this happened, they have this quote where they're talking to people the workers administering the executions inside. And someone's saying, I heard some guys saying, these guys are really muscular. It's going to be harder. Maybe the nervous system of the Black inmate works different. So there's this idea that executing people based on their race is going to be more difficult. It might be more challenging to do, and that there's a reason why we're seeing more box executions. However, at the same time, a spiritual advisor who's been in the death chamber for several executions noted how differently they were being treated, right? The restraints I've seen on Black folk have been unquestionably tighter. So it's presumed that they're going to fight, they're going to be aggressive. So they are tied down harder and have greater restraints, which also could be the reason why their executions are more likely to be botched, right? Okay. Another example I want to go to is pelvic exams. So people are probably familiar with J. Marion Sims, the quote unquote father of gynecology, who I think we do not give that title to anymore. So this is a quote from him, and he talked about we know the names of 3 people that he experimented on, Lucy, Betsy, and Arachna. And he talked about how I got 3 or 4 more to experiment on. There was never any time I could not on any day have had a subject for operation, right? So we know that he had many people that he had exchanges with other slaveholders in the area to both provide medical care, but also to advance his technologies. He's credited with inventing the speculum. He took a spoon and bent it in order to do an exam, which nobody likes the speculum, but we're all glad it exists. That's a positive thing. I'm assuming there's experts in the room who can say more. But when we think about this technology and we think about moving in the future, just last month, the Health and Human Services Guidance released new guidelines requiring consent for pelvic, breast, and other sensitive examinations. So prior to this, it was common practice for patients to undergo unconsented intimate exams while unconscious, right? So when someone was having a surgery, students would practice performing pelvic exams on them without their knowledge or without full informed consent. A study that came out about 2 years ago found that Black patients were 4 times as likely to have undergone an unconsented pelvic exam. And this is done for the good of society. It's done to practice and to learn for education. And it's based on a concern that if you ask patients if you can do it, they'll say no, which first isn't founded in evidence. All the evidence suggests that when you ask people, most people say yes to allowing students to practice things on them. But if we assume people will say no and we do it anyway, that really brings into challenges ideas of informed consent and what we're doing in that practice. But 4 times as likely to happen on Black patients. That's very disturbing. I also wonder if it has to do with where and how we train medical students and which hospitals are more likely to have medical students and residents working on them, which we'll talk more about in a second. So this idea of whose people's bodies are for, therefore our training, therefore our experimentation, has been a constant feature. But I wanted to say, and I meant to say at the very beginning, some of what I'm going to say is very disturbing. There's also disturbing images. This is a disturbing one. Talking about someone describing their experience of receiving a pap smear in prison. And she said, we were lined up like cattle to get pap smear. That language of cattle is something that comes up a lot in my research. You should have seen pap smear day. We'd stand here in these moo-moos. We'd stand in line, get on the bed. There'd be blood, KY jelly on the floor. It was gross. They were doing them back to back. And it was horrible. He, the doctor, will eat lunch and give a pap smear at the same time. It's the truth. He doesn't use gloves, just back to back. And everybody's in line. It's not just one person he's taking advantage of. Everybody's in line. It's line clear down the hallway. And it seemed normal when you're in there. And that's the thing about this whole thing is I look back and I think, how did I not know that this shit wasn't normal? It fucks me up just thinking about that. And there have been several lawsuits at the time about this, reports by nurses who also said that this doctor would not use gloves or use only one glove or would eat while doing exams. This is a notorious doctor who's not working in the prison anymore, but didn't face penalties for this and was very involved in many of the forced sterilizations that we'll talk about in a few minutes. So this idea of whose bodies are worthy and our right to people's bodies has been this continual thread throughout this history, right? And then finally, this might be my last historical example. People are familiar with the Public Health Service study of untreated syphilis at Tuskegee, which I think I added an extra study in there, but I've been trying not to just say the Tuskegee study to say the full name, and I put too many words because it's already really long. So people are familiar with that. People, Black men with syphilis were left untreated to see the progression of the disease. Obviously, a big foundational thing in modern bioethics is understanding how and why this was wrong. But I wanted to talk about the way that this was grounded in our understanding of the Black body at the time. So I'm quoting from Dorothy Roberts in Fatal Invention talks about this. She describes Dr. Thomas Merle in 1910, writing in JAMA, about why it was most important to study syphilis in Black patients and why it wasn't useful in white patients. And she says the high rates of syphilis were due to physical and moral degeneration of Blacks, right, due to the emancipation from slavery. And he said, if the healthy Negro is a political menace, then the disease one is doubly a social menace. The future of the Negro lies more in the research laboratory than in the schools. So we shouldn't be sending Black people to be educated, to learn about health, to treat others. Their value was a study for research, right? For us to be able to use that knowledge to benefit other communities. And this is echoed then in the Flexner report on medical education. So the Flexner report looked at medical education in our country. It streamlined medical training, made lots of advances in how we consider and how medical training operates sort of across the country. But importantly, it had some things to say about the training of non-white doctors. So the recommendations from this study that were implemented was to close all but 2 historically Black medical schools. And the author of this report wrote that the only reason to have Black doctors was because 10 million of them, Black people, live in close contact with 60 million whites, right? We needed to have some Black people who were trained, not as surgeons, but as people who were knowledgeable about hygiene and spread of disease to protect white people from the diseases that were inherently spreading in the Black community. And so he said the Negro must be educated, not for his sake, but for ours. But importantly, they did that. I mean, they closed Black medical schools. Black doctors were never supposed to treat white patients and really weren't supposed to be doing high levels of care. At this time, there was a belief that Black people may die out because of diseases that we were predisposed to. So it was really a waste of time. And also, the only reason to treat was to stop the spread of disease to white communities. And LaTanya Trotter is doing a lot of thinking about this. And she's talked about both how medicine produces racial knowledge and racial difference, and the way we've talked about, right? We had this science to identify, name races, describe, and sort of cement the idea of racial differences. But she talks about how medicine produces and requires Black vulnerability, right? Black doctors become a threat because if Black patients go to Black doctors, they do not need to avail themselves of white doctors. They don't have to go to white institutions where they can be experimented on, trained on, practiced on. If they were being seen by doctors of their own. Medicine was depending on the extraction of racialized and gendered labor through the availability of Black bodies, right? So this is something we see throughout the way we've organized our healthcare, the way we've organized a lot of our research throughout historically, but also still into today, right? And so people, obviously, we're at Johns Hopkins, people are familiar with Henrietta Lacks, what happened to her. I always am sort of like, is Henrietta Lacks, how do we think about this in bioethics? So much of what happened is really not that different than what would happen today. There'd be a consent form, but like, we take samples and they're not used for the benefit of the patient and they don't know what happens to them and people profit. Like none of that has really changed, right? There's many things here that are core to the way we deliver healthcare. But what I think is important, it's a few things, is why was Henrietta Lacks getting care here? You know, Johns Hopkins was providing care for, I think, like half of Baltimore at the time, high proportion of patients who were unable to pay. And then there's this discourse that happened here, it happened in other parts of the country too, this idea of night doctors or body snatchers, right? People taking bodies, primarily Black bodies, to learn on out of graves. So Henrietta Lacks didn't have a choice necessarily to be here. This was the place of providing care. And it was very much seen that offering your samples was a condition of care. That I think has not changed necessarily that much. When you go to a teaching hospital, there's an expectation that part of the exchange of you getting care is being learned upon, either research for the greater good, through training for the greater good. This has been sort of how we've established and justified these types of systems, right? But what I didn't know until recently that, again, links this back to my research in an interesting way, is there was an oncologist, Chester Southam, who took HeLa cells, as everybody did. As we know, HeLa cells are absolutely everywhere. And he injected them into people incarcerated in the Ohio State Penitentiary without informed consent to see if people could become immune to cancer. And our buddy Chester did a lot of shady ethical things. He did a lot of consent or a lot of research involving lack of consent in different types of institutions for mental institutions of various kinds. He did work in Africa, injecting people with various things to see what would happen. He went on to he was the president of the AACR, American Association of Cancer Research. And really only this became a scandal when he started working on healthy patients in hospitals. But this was part of his MO, was like, we have these bodies available. How do we understand how science is advancing, right? And so this idea, and this, this quote comes from LaTanya, free care wasn't actually free, right? So academic medical care centers established as a site of free care, right? But Black bodies are used for capitalist and medical extraction. We learn from them in various ways. That has been how we've developed so much of our knowledge. And so, as I said, Trotter argued this led to the intentional underproduction of Black physicians because it would threaten Black vulnerability. They wouldn't need to come there to get care. So my colleague, Amy Medeiros and Amy is a historian, has been studying medical research at some of the prisons in California. And we've been toying with this idea of safety, right? So many of the studies that were done in the prison context, in institutions on Black bodies, like in the syphilis study, were testing things, right? We need to know if something's safe. We need to know the outcome of this. Even if we look back at J. Marion Sims, like he did, he practiced, did different types of surgical procedures without anesthetic on Black bodies so that then he could do it later with anesthetic on white bodies. We're testing the safety things on these specific types of bodies to see what this will mean for greater ideas of safety. And to me, that puts into conversation this idea of public safety, right? We put people in prisons and jails for this idea of public safety, to create safety from, right? Safety for whom, safety from whom, not always clear. And then we have this idea of safety net hospitals, right? That are providing some measure of safety within our society. And so I've been really interested in thinking about how this idea of safety is constructed, right? How do we decide on whom it is safer to practice or to advance our knowledge for the benefit of whom? Who are we deciding needs to be protected, needs to be safe from whom? Who are we supposed to be catching in these various forms of safety nets? And Amy pointed me to sort of thinking about an example of putting two photographs side by side, which again, this is my disclosure that these photographs are challenging. So on the right, we have one of the most famous photos of sort of the abolition era, my right, your left, which is someone who freed himself, showing his scars from being whipped during slavery, right? And when I see this, I'm just thinking about this idea of drapetomania, that in some ways it's possible that these scars are curative, right? This was done as a way to cure a disease that he had based on his race. This was both a part of maintaining public safety, he needed to stay where he was, and a way to advance medicine and cure a disease, right? I obviously don't think that in the mind of what was being done at the time. And on the left, my left, this is from the cover of Acres of Skin, right? So this is someone in the prisons in Pennsylvania who is being experimented on by Dr. Kligman from University of Pennsylvania and others on that team. So you can see on his back all the wounds from being injected with various chemicals over time. And it's the same idea of like public safety. He's there for the safety of the public. Cure for disease being embedded in his skin. And both of these happening on the bodies of Black men, right? Both this is appropriate as a form of punishment based on who you are in our society. And this is how we're advancing healing for someone in some way, right? The messiness of this construction of for whom and by whom, of safety for some as a reason for advancing research, medicine, and clinical care in different ways, the messiness of that is it allows it to flourish and continue to evolve in ways that feel justified in our society. Okay, I focused a lot on the East Coast, but I'm gonna go to San Francisco because we too have racism in San Francisco and a really messy history. So UCSF, where I am, it's a medical school. We're only a graduate institution. We were founded by a man named Hugh Toland, who my colleague Amy has been doing some interesting research about, his relationship to the plantations in South Carolina, his potential overlaps and being a buddy or a contemporary of J. Marion Sims, which is interesting. So he established Toland Medical College, as was known at the time, in 1864, right next to San Francisco City and County Hospital, right? What is now San Francisco General. All these buildings are in different places, different locations, but these are what we're talking about. Just a month after classes began, the state of California approved the dissection law permitting pauper bodies to be studied by accredited physicians, which opened the way for Tolan to allow students to gain experience doing dissection. So this hospital was open to allow, because they had these bodies available in need of practice on in the hospital, right? They were able to get access to poor bodies to do further research and training on. And how has that continued to today, right? Like I just keep thinking about J. Marion Sims, I always have more bodies to experiment on, right? We chose and open hospitals or chose and open medical colleges at the site of these hospitals where patients were. And some of that's because how was care delivered? When did hospitals start? Hospitals were a site of where poor people went, rich people got care in the home, but it's always been understood that a condition of getting treatment is allowing students to learn on you. And that's the price that you pay, right? And so today, it's a Google map, UCSF Medical Center and what is now Zuckerberg San Francisco General Hospital are pretty close together. They're only about 1.5 miles apart. There's a shuttle that goes in between. All the faculty and trainees have UCSF email addresses. There's lots of overlap between them. But the patient scene of these institutions are really different, right? So our racial breakdown in San Francisco, we're like a little more than 1/3 white, a little more than 1/3 Asian. San Francisco's had a lot of gentrification. We push out a lot of people because it's very expensive to live there. But if we look at who gets care, this is breast cancer patients at UCSF. You see predominantly white. Breast cancer patients at SFGH, not predominantly white, drastically different patient population. Same thing in prostate cancer, overwhelmingly white at UCSF, mostly Black or more predominantly Black and Hispanic at SFGH. So these institutions are intentionally based on how we pay for that care, based on Medicaid and other reimbursement rates, seeing different patients. And what's interesting is that providers working in different safety net clinics in the city talk about they think their patients get better care at the safety net. Like we know how to take care of translations, we know how to set up transportation, we know the patient population, we know how to manage patient insurance. And there's always this idea of mission-driven care, right? We are there because we want to serve this patient population. They're not going to get as good of care at UCSF. But talking to patients at UCSF, this is specifically in cancer, this area I was doing this research in, talking about trials, a huge difference is patients are offered clinical trials when they're therapeutic trials, right, at UCSF, and they're not at San Francisco General. Trials aren't a luxury. They're an opportunity to have better care, and this is discriminatory. It means that people who are poor and down their luck don't have the opportunity for better care. And it's interesting, a colleague of mine, Kim Rhodes, has talked about how patients enrolled in clinical trials, regardless of whether they receive the new therapeutic intervention, this is in cancer, all have better outcomes, right? When you're in a clinical trial, they're watching you closely, you get better care. So we've seen this flip that when research is done for therapeutic benefit in the context of things like cancer, when it's based on having a disease, it's predominantly white people who are enrolled and engaged and people of color are pushed out, right? When it's still today, when it's trials that aren't related to needing to have the disease, it's predominantly Black and brown people who are in the phase 1 trials being experimented on, right? And I also want to talk about the training here. So when in talking to residents and early career folks and medical students, people talk about getting more autonomy at SFGH. They feel like they can do more procedures. They are able to start procedures without attending presence. Someone was talking about where they were going to go for another level of training and being sort of told not to go to a certain other fancy institution, saying there's cutting edge surgeries, but you won't get to do any of it. And you have to train while you'll get to be doing the procedures yourself. And it was interesting to looking at how different residency programs sell their programs to med students who might want to go there. And they, this is language I've taken from like different websites and things, offers residents a chance to train with one of my most diverse and medically complicated populations in the US. So really selling the things you'll get to see in this patient population. Another important highlight is how thankful our patients are for the care they're provided by our resident. So patients should have gratitude for getting your care, and that's a reason to want to go, is the extended gratitude at these types of at safety net clinics versus the academic medical center side. And I'm just really fascinated by what that means and the different ways in which training might happen across these institutions too. The last thing on UCSF I'll just note is we have our own history with prison research. So there were 2 clinicians who trained with Kligman in Philadelphia, who was the one involved in Acres of Skin, right? Which I don't think I said. The reason that that's the title of that book was because of a quote of him walking in and saying, all I saw were acres of skin, right? Like he just saw bodies to be tested upon. Anyway, one of those faculty members, Howard Maybach, is still on faculty at UCSF. He still publishes. He's still being paid. He and another faculty member were recruited to UCSF based on the promise of having one of our medical facilities available as test subjects for research, right? One of our prison medical facilities. It was a selling point. And, he perpetuated, did research on people who were incarcerated until the 70s when it no longer was allowed to be done. And he sort of, when this came to light in 2022, he said, I regret having participated in research that didn't comply with contemporary standards, but he said, I believe that UCSF collaboration provided several benefits to the prisoners, and he doesn't think anyone was harmed. So he believes that this was a justifiable way to advance science, and he went on to do a lot of science based on racial differences in skin, which I think is quite interesting. Okay, so how do we put this together, and what does this mean for how care is delivered today and the way that carcerality and racism are a part of how we do care? So transitioning to my last thing, which I'm going to tell you one story and then talk a little bit about what I've been studying related to care for incarcerated patients. So I'm going to tell you a story of someone who asked me to call her Goose. Goose was incarcerated. She's a Black woman. While she was inside, she had a very serious stroke when she was 37 years old, which is extremely young. Less than a year later, while she's still recovering, she fainted. She was on blood thinners. At the time, she had some testing. It was revealed she had fibroid tumors. The doctor told her she needed to have surgery to have them removed. This can be really reasonable if you're having heavy bleeding, you can see the logic here, but she originally refused. She didn't want to have surgery. She was scared. She didn't want to have her fibroids removed. The nurse told her, either you're going to do what he says, the doctor, or he's not going to want to help you. So she felt like she didn't have a choice. If she didn't do this, she wasn't going to get offered care. This is something I've heard a lot, is people who were sterilized felt like, I'm being offered something that's better than what so many other people were getting. So she agrees. She goes to the hospital to have her surgery to have her fibroids removed. She's in recovery, talking to the doctor after the procedure is over. He's going over things with her. And as they're going there's something in that didn't make sense to her. And she said, I thought they were going to take the fibroid tumors out. And the doctor said, no, you had a partial hysterectomy. So obviously that is something that I think is quite common. You might intend or hope you can take the fibroids out. It might not be possible to do. You do a hysterectomy. But that wasn't explained to her as a possibility. She didn't know that might happen. So she was pretty depressed after this. She was very sad that she wasn't going to be able to have children. She talks about, I didn't think Black people would get depressed if you couldn't have children. I thought that was a thing that white people did, that we were stronger than that. But she felt it for a very long time. She'd feel very sad when she saw children in the visiting room and other things. And then she got out, she went home. She was having lots of complications, lots of health issues, went to the doctor, was telling them that she had a partial hysterectomy. And she said, the doctor said, Miss, you don't have anything up there. And I said, what? And he said, you don't have anything. And that's when she found out that she had a full abdominal hysterectomy, something she hadn't realized and didn't realize until she came home, right? So this has been the site of a lot of my research, has been looking at forced sterilizations that happen in the prison context. And I wanted to just bring in a little bit more history to set this up. So talking about eugenics, folks are familiar with eugenics as the science of how to arrange reproduction within a human population to increase heritable characteristics. It was law in our country, legally allowed for a very long time. The famous case of Buck v. Bell, I always like to point out, and that in this case, which established that this was constitutional, part of the quote from Justice Oliver Wendell Holmes said, it's better for all the world if instead of waiting to execute degenerate offspring for crime or to let them starve for an imbecility, society can prevent those from continuing their kind. So criminality was always embedded into this idea. In state eugenics programs across our country, more than 60,000 people were sterilized. California had the most far-reaching program, more than 20,000 people were sterilized. This practice sort of petered off in the 1950s. Eugenics, forced sterilization specifically, sort of fell out of favor, and many of these institutions where people were housed began to close. But it never stopped in California. More than 200 women were sterilized in LA County at what was at the time, it changed its name, and now I'm like, which one is it? LA County USC at the time. Mostly Latino women who didn't speak English. They sued. It became a very high-profile case because of their advocacy, which is what led finally in 1979 for the state eugenics program in California to end. Our governor apologized, said, wow, that was bad. We shouldn't have been doing that. But at the time, my colleague Nicole Novak has talked about how we had a really high rate of people who were institutionalized in mental hospitals in the first half of the 20th century. As that began to decline, we see the sort of sharp increase of people institutionalized in carceral facilities. So we've always maintained a pretty sizable rate of people who are institutionalized. And it's not surprising that we then continue the same practice of forcible sterilization, this time on people who were in the prisons. And so, what I really think about is the way that racial capitalism, which is where I started, and eugenics have always been really tied together. They've always been about the same project. We can see really clearly in history that the racial categorization necessary for things like enslavement, coupled with the need for additional people to work the land, to be slaves, facilitated a logic where family could be weaponized against people, right? We had to make reproductive increase. We had to create new humans, but we couldn't have a tie that it gave people a right to stay together. We had to separate it in this way. So this eugenic logic of what is family, who deserves family, who has the right to decide if and when they reproduce, has always come along with eugenics, right? And prisons has been this extension of that project. So the same doctor that I talked about before about Pap smear day had this quote when these sterilizations came to light. He was involved with a huge number of them. When asked about the cost of the sterilizations to the state, he said, over a 10-year period, it's not a huge amount of money compared to what you save in welfare paying for these unwanted children as they procreate more. The thing I always like to point out is people have this number. People probably have heard this 144, 148, depending on the time and that this came out, of people who were sterilized. This was just the number of tubal ligations that occurred inside. During this audit that the state done, they found almost 800 people who had some form of sterilizing procedure. And this was only 2005 through fiscal year 2012. I'm like, how many years is this? When did fiscal year start? I don't know. But anyway, in this 7 or 8 year period. So we'll never fully know how many people were forcibly sterilized. And there were many people who had other types of sterilizing procedure like goose without full and proper informed consent. So the numbers of people who may have had a sterilizing procedure that was unwanted or unknown, we don't know how many people that is. But importantly, we often center the prisons in this. We center Heinrich specifically, who was awful and channeled many people forward to these procedures. But these procedures were happening in community and academic hospitals, and at least 23 hospitals in California, including UCs, including hospitals where we train our residents at UCSF, or our medical students. And how is this possible? How do we understand this, right? And so I've been doing interviews with healthcare providers and trying to think about the conditions of care in the clinic and what this means, right? Most providers don't know this specific law, but many receive little or no training on care for incarcerated patients at all. The policies are often really confusing. People don't know what the policies are, or they're told policies that are not correct. And so I think we really have to think about how we care for incarcerated patients and what policing really looks like in the hospital setting. So I said I would come back to this, and I am, this idea of carcerality in care. So first, I just wanted to highlight that I think it's interesting. I've been rewatching Grey's Anatomy. I don't know why, but anyway, there's this idea embedded in Grey's Anatomy that patients want to go to the hospital for their own benefit because they get out of prison or jail. And I think this is sort of a media discourse. But I want to note that for many people describe really horrific conditions of getting to a clinic in the first place, being strip searched on the way in and out, being really jostled about in really violent ways in the van while you're being driven there, feeling humiliated on purpose. And this is a patient saying, you walk in there with shackles on, they're going to give you the minimum, you're not a priority. People feel very devalued and dehumanized often when they seek care. I'm just going to skip over this. So there's been some interesting studies about caring for incarcerated patients, and I want to pull out a few things. First, just noting, this particular survey found that, in this hospital that regularly serves incarcerated patients, almost everyone is cared for a patient while they were shackled, right? So 97.5% of providers in this survey, and 2/3 of providers have, this says carded, it should say cared for a patient who was shackled while they were intubated and sedated. So definitely not moving. The places we have the most restrictions on shackling in the hospital setting is in labor and delivery. But one survey of perinatal nurses found that only 7% correctly identified whether their states had shackling laws. So the place where it's most known, it is still not always conveyed what happens. And shackling can be a source of moral distress for both patients and providers, right? There's a lot of misconceptions around what shackling really means. First, that it doesn't cause harm. It can cause a lot of harm. In most places, and providers can ask that a patient be unshackled, especially if it's for patient care, but providers don't know that, or they, are told no and go along with what the person in the room tells them the rules are, and that it keeps people safe. I think we have this idea when I've talked about this work in other places, I've sort of been told, well, of course they're shackled, they're violent, but no, if you are, first of all, many people who are incarcerated, most people in jails have not been convicted of anything. Most people in prisons and jails are not there for violent crimes. And even then, those people who are there for violent crimes does not mean that they pose any particular threat to the healthcare worker, right? There's lots of people not me, because I'm very meek, but there are people who might engage in violence against. That doesn't mean you're a threat to everybody. And I wanted to point to this article by one of the same authors as the last one, who this picture, which again, trigger warning, but I've already shown you, shows an ulcer at the wrist, right, from shackling. Like, this causes harm. And I just continue to think about the violence that's inflicted on the system. This is someone being shackled for a long period of time while in the hospital, when they came into the hospital. It was put on at the site of medical care and caused additional harm. And I think that's something we have to remember. And we've just been seeing reports coming out of some of the prison camps in the Middle East about amputations happening because of excessively tight shackling. So this is a harm that happens. Just a couple more examples I'll note is just the presence of various forms of police at the bedside. Several studies have shown that police present can interrupt medical evaluation and treatment. It can compromise patient privacy. So often information is relayed with someone present who is not a family member, who the person would not choose. What does that mean? And it can deter members of the public from seeking care when they know that the environments are heavily policed. And people really feel like that it interrupts the care they're able to give. And this is a provider talking about it being really unnerving. And there was a case, I can't do math. What was that? 7 years ago, a nurse was arrested. She would not allow them to take do a blood test for drugs without a warrant. And she was violently arrested and dragged out of the hospital, right? So it's hard for providers to stand against police when they're telling them what they need to do, even when it's against the laws. And then I just want to note a few things. This is going to the middle of the spectrum. The ways in which I think healthcare can advance it, even outside of people who are incarcerated, right? So involuntary commitment, I don't necessarily want to come out for or against a specific medical intervention, but just I think it's important that we know that is a carceral intervention, right? When we force someone to care, people experience that as imprisonment, even if that's not what we mean. And then when we do, in the psychiatric inpatient setting, studies have shown there's racial disparities in restraint use. We still apply things more severely to people we perceive to be threatening, who tend to be Black and brown people. It's really hard because violence in healthcare is real. How do we respond to that? What do we do? Is a huge challenge. There were 2 papers that came out the same day, which I thought was just interesting because I don't think they knew about each other in advance. One was sort of talking about this idea of behavioral contracts. So hospitals, when a patient is seen as aggressive or inappropriate or sometimes violent in various ways, will impose contracts limiting the activities they're allowed to do. Sometimes it'll be like you can't show an attitude or you can't use certain language with the nursing staff. Sometimes they'll take away their TVs or their phones. Sometimes they'll limit visitors being present. There's been cases of people dying without family because of this. And this research was showing that there isn't really good evidence that's effective. But at the same time, there was a piece that sort of talked about in I think a positive way that many states I think it was 29 states have passed or are trying to enact laws to allow healthcare facilities to have independent police forces. So the idea that the solution is more policing in hospitals. And this really matters, right? So hospitals that primarily serve Black and brown patients, hospitals that are public hospitals that take Medicaid, Medicaid, are much more already likely to have police and much more likely to have security who can arrest. And that matters because police carry guns at much higher rates than other forms of security. And I'll also note that there's different hospitals there's many hospitals that require the presence of security personnel when a patient is suicidal, when they're applying restraints, right? When they're being involuntarily committed. And often that might be a police officer. So what does that mean? And how do we think about that? And then I just want to note that often healthcare is the source of putting people into the criminal legal system. So people might remember last fall, the case of Brittany Watts of Ohio had a miscarriage at 22 weeks at home. A nurse, she sought help several times, but a nurse called the police and she was arrested. And eventually they did not end up charging her, the grand jury. But she was, that's a horrific trauma, right? At the same time we were forcibly sterilizing people in California, we jailed women for having miscarriages in the state of California. And almost always arrests of interventions on pregnant people, almost all are done by healthcare staff, right? The majority come from hospital staff who initiate those investigations. And one study found that 52% of women prosecuted are Black. 71% are low income. And in 2/3 of the cases, there's no outcome reported in the health of the fetus at all. And then last, I just want to note, I think that there's ways in which even this is my like coercion side, the like least carceral side of the spectrum, where I think we have to think really carefully about how we care for patients broadly in so many ways. And the language we use for patients is the one example I'll cite here. Black patients and poor patients are 2.5 times as likely to have a negative descriptor about them in the EHR, so labeling them as aggressive, even things like non-compliant or refusing care, labeling them as unpleasant. All of that follows you forever and makes it even more likely there'll be a police intervention of some kind, a carceral intervention, if you show any type of resistance to the care you're being offered. So, I'm going to end with just big old questions. What do we do about any of this? I don't know the answer, but I have a few ideas. I think we have to think about how we're training our clinicians to empower them to deny police access or to think about our carceral interventions in critical ways, changing our policies about police presence in our healthcare spaces and in our academic spaces, and our policies around shackling. And then, of course, like advocating for policies that lead to better care. And I'll just note that I think, sorry, I can't like see through the next slide, so I'm just clicking through them really quickly. It's really hard to imagine what reform looks like in this setting. Angela Davis sort of really talks about this and talks about the idea of non-reformist reform versus reform. We need better care, but how do we do it in ways that doesn't further legitimize these institutions? That's not just training police to be better. That's not just putting more money into prisons and jails. Reform can often look like people signing a consent form before they have an exam while they're unconscious, or people signing a consent form before the materials are taken from them. They don't know what happens with it. Reform looks like lots of older adults receiving care, but still in prisons and jails. So I really encourage people to do reading on ideas of abolition. I love Obasagi's work on this, critical resistance and abolition feminisms. There's a book, Abolition Feminism, that's recent, I think is really great for thinking about how we imagine a society in which safety and security aren't just premised on violence, and how we think about collective commitment, right? So I think in the field of bioethics, we think about investing in our community, bringing people together, deconstructing violence, and really thinking about what justice means. And I'm way over time, but not over past 1 o'clock, so it's a win. Thank you all so much.
Great, thank you so much. That was a tremendous and tremendously disturbing tour de force through
400 years of history in 45 minutes.
Well, like one slice of 400 years of history. So thank you very much. We have time for maybe 1 or 2 questions. Maybe I'll start, which is your point, and we talked briefly about this. You alluded to this when we met before your talk, that the notion of safety and what we mean with the word safety, which when you said it in my office, I was like, I don't know what she's talking about there. Like, what do you mean by that? And that Venn diagram you had of safety nets and safety, I can't remember all of the words there, but really got me thinking. I mean, how are you further sort of exploring that and deconstructing that?
I know. I'm really, this is a new concept that I'm starting to explore. So tell me what you think, and it will end up in the next presentation I give. That's how this works. So public safety, the idea of safety is obviously a big part of why we have prisons and jails. It's why we have police, is to maintain safety. But this question is safety for whom and safety from what? Like, police make some communities feel safer. They don't make other communities feel safer. Prisons make some people, the existence of them makes some people feel safer. People who are in prisons are not safe in those spaces at all. And I think it's something I've wrestled with a ton, because even things like, having someone be shackled at the bedside and a guard in the room while someone's having surgery, or someone's having an intimate exam, or someone's making a life or death decision that's done for safety. Is the patient safer because of that? Their health isn't safer. If we think about, like, if you have a surgery, like oftentimes they want you to walk, after your surgery, you're supposed to get up right away. If you can't do that, you're going to be at greater risk for falls later. You're going to be at greater risk of infection. You're going to be at greater risk of all kinds of things. I'm not a surgeon, but I know that you're supposed to walk after surgery. So we're not doing it for the safety of the patient. We're doing it for the safety of the doctors. Does the doctor know it's for their safety? How do they feel about that? Who gets to decide, make these decisions? And I think that that is inconsistent. I think it's based in this long history, and I think we don't interrogate that enough. And the same thing goes with like, we all take on risk. Like the whole idea of research and healthcare is we balance risk and benefits, right? This idea of safety comes in that say it's okay, I'm going to do this procedure, here are the risks, but I think the benefits outweigh this. I'm going to participate in this research, here are the risks, but the benefits outweigh that. But if we don't give everyone equal entree into those spaces, if some people are asked to take on more of the risk, whether that's more of the risk of certain types of research that are really dangerous on their bodies, whether that's more of the risk of having a higher proportion of trainees learn on them, which of course we have to train medical students and residents and all, like that is a necessary thing we have to do. But if not everyone has the same likelihood of that or experiences that in the same way, we're prioritizing safety or security for some over others. And I just think we don't make that very visible. I think we take some of these concepts for granted, that the same systems make us all safe, and they just have never done that, right? IRBs have never equally made all patients safe. Hospitals have never equally made all patients safe. Polices have never made all communities safe. I don't know if I answered anything except to bring up more questions, but
No.
yeah.
Thank you. And we think about that. Yeah. Oh, thank you.
Oh, thanks. Thank you. This was wonderful. I think, well, I was going to ask you to maybe share a bit more about your thinking on the different classifications. I think you turned a new other class.
Yeah. I don't know. I don't know if it's the right word, but that's what I said.
Okay. But now that I just described a little bit more about the different elements of safety and how they're constructed, I think maybe it would be fruitful to put those two to, I don't know, kind of use the work on safety to inform your.
I like that a lot, right? Because what we've done is come up with new ways that we're sort of labeling unsafe bodies in different spaces, right? Unsafe for various things. And so if we think about the eugenics, this group of people was unsafe for childbearing, right? You have these classification of diagnosis, some of which were real, some weren't. You're sort of unsafe to be a member for society. We put you in an institution. You shouldn't raise children anymore. Prison, you're incarcerated because you're not safe to be in our society for whatever reason. So how do we think about how, as we continue to reify that idea and change who counts for safety or who's worthy of safety? I think there's something interesting there. So I like that. Thank you.
We are at the top of the hour, so please start the better.
Thank you all. Might be the time running out.